Assalamu alaikum. My name is Humaira Ansari and my roll number is BP1650085. I am from group number 21. The main topic is cardiac arrhythmia, but the subtopic which I am covering here is atrial fibrillation. Before going to the case study, first we have to know what is atrial fibrillation. Atrial fibrillation is an irregular and often rapid heart rate that can increase the risk of stroke, heart failure, and other heart-related complications. During atrial fibrillation, the heart upper two chamber, that is the atrias, beat irregularly, out of the coordination with the lower chamber, that is the ventricles of the heart. Major concern with the atrial fibrillation is the potential to develop the blood clot with the upper chamber of the heart. These blood clots forming in the heart may circulate to the other organs and can lead to the blockage. These are the symptoms of atrial fibrillation. Some people with atrial fibrillation does not have any symptoms and they are unaware of your condition. But the main symptoms include palpitation. Actually, palpitation is the racing and uncomfortable heartbeat. The second symptom is weakness, reduced ability to exercise, fatigue, and shortness of breath. The possible causes which can cause atrial fibrillation are as follows. The main possible cause is high blood pressure, and the other possible causes are heart attack, coronary artery disease, previous heart surgery, and stress and sleep apnea may also causes the atrial fibrillation. These are the factors for risk factors for atrial fibrillation. Number one is the age. The older the patient, the greater the chances of developing the atrial fibrillation. Number two is the heart disease. If the person having the heart disease such as congestive heart failure, coronary artery disease, the person has an increased risk of developing the atrial fibrillation. Number third is the obesity. People who are obese are at a higher risk of developing the atrial fibrillation. High blood pressure is the major risk factor. If the person has higher blood pressure, then the developing atrial fibrillation is at high risk. Family history, an increased risk of atrial fibrillation is present in some families of also, and drinking alcohol. If patient drink alcohol, so the risk factor for atrial fibrillation increases. The complication of atrial fibrillation, there are two complications of atrial fibrillation. Number one is the stroke, and number two is the heart failure. In atrial fibrillation, the chaotic rhythm may causes the blood to pool in your heart upper chamber and form blood clot. If the blood clot forms, it could dislodge from the heart and travel into your brain. There might be block of blood flow and causes the stroke. And number two complication is the heart failure. Atrial fibrillation, especially if not controlled, may weaken the heart and lead to the heart failure. There are two goals of the therapy for atrial fibrillation. The initial goal of the treatment is to relieve the symptoms and reduce the risk of a stroke. Slowing the ventricular rate during the atrial fibrillation can help accomplish the first role in most patients. Anticoagulant can help achieve the second role. Cardioversion. What is cardioversion? Cardioversion means the medical procedure that restores the heart normal rhythm. Cardioversion to normal sinus rhythm can be delayed unless the patient is hemodynamically compromised due to the atrial fibrillation. The treatment option for atrial fibrillation. There are two treatment options for atrial fibrillation. Number one is the rate control and number two is the rhythm control. Mostly we prefer the rate control. In rate control, we give the beta blocker along with digoxin and anticoagulant for the patient with the risk of stroke. If the patient does not, if asthmatic for example, so we cannot give the beta blocker because beta blocker can causes the narrowing of the airways and causes the asthmatic attack. So in replacement of beta blocker, we give the calcium channel blocker along with the digoxin and give anticoagulant to all the patients with the high risk of stroke. Rhythm control. The second strategy is the rhythm control. In rhythm control, we have further 4 treatment options. Number 1 is giving the anti-arrhythmic drugs such as amiodarone is mostly given, and quinidine, and there are other drugs that are come under the category of anti-arrhythmic drug. Number 2 is the catheter ablation. This is also given by pulmonary vein ablation, linear ligands. The third is the defibrillator. Atrial defibrillators are given, and the last is the surgery by maze procedure. In all these 4 procedures, we also giving the anticoagulant for the patient with risk of stroke. These are the treatment options for atrial fibrillation. CHATS2 score for atrial fibrillation stroke risk. This is the CHATS2 score is the can help the physician estimate the stroke risk in the patient with non-valvular atrial fibrillation and determine which antithrombotic therapy is most appropriate. In CHATS2 score, it stands for C stands for congestive heart failure, hypertension, age, diabetes, and assisted stroke. We give the number if the patient have congestive heart failure, number 1 give the number, and if hypertension give 1, or if the total number of the scores of the chat is 0, there is the low risk of developing the stroke, and we give the anticoagulant therapy by giving the aspirin only. If the total score of the chat is 1, then the risk of developing the stroke is moderate, and we give either warfarin or either aspirin as anticoagulant therapy. If the score of the chat is 2 or greater, then we give the warfarin only, and there is the moderate or high risk of developing the stroke. This is how we give the anticoagulant in the patients. Now the case study. Here we have Mr. John, 61 years old, is admitted to the emergency assessment unit at his local hospital, complaint of palpitation, breathlessness, and dizziness. He has a 5-day history of dizziness and palpitation. In the last 24 hours, he complained additionally of shortness of breath and collapsed at home, and was then admitted to hospital by the emergency department. He experienced the similar symptoms 2 months ago but did not seek any medical advice at that time and recovered quickly. He has hypertension, which was diagnosed 5 years ago. No previous history of cardiovascular disease. The patient is a regular cigarette smoker and take more than 20 per day, and drink 20 units of alcohol per day. He has been prescribed the lisinopril. Lisinopril is the ACE inhibitor, and here lisinopril is given because the patient is hypertensive for last 5 years. That's why lisinopril tablet 20 mg once daily, but was poorly contained with the treatment. John blood pressure is 100 by 70 mmHg. Heart rate is 175 beats per minute, which is irregular, and respiratory rate is 25 beats per minute. And full blood count, liver function test, electrolyte, renal function test, all are normal at the time of the admission and throughout the admission to the discharge from the hospital. Now the SOAP notes of this case study. SOAP notes. First, the subject. The chief complaint: patient is complaining of palpitation, breathlessness, and dizziness. Age is 61 years and gender is male. History of illness: he experienced the similar symptoms 2 months ago but did not seek the medical advice at that time and quickly recovered. Onset of the chief complaint: he has a 5-day history of dizziness and palpitation. Medical history: he has the hypertension for last 5 years. Social history: patient is regular cigarette smoker, more than 20 per day, and drink approximately 20 units of alcohol. Current medication and allergy: current medication is lisinopril, which is given for hypertension, tablet 20 mg once daily, and patient has no allergy. The objective and the vital signs are the blood pressure, which is 100 by 70 mmHg. Heart rate is 175 beats per minute, which is irregular, and 25 beats per minute is the respiratory rate. The laboratory data, that is blood count, LFT, electrolyte and renal function, all are normal. Now the assessment. By the shortness of breath, dizziness and palpitation, these all are the indicator for the atrial fibrillation. Patient irregular heart rate, that is 170 beats per minute, respiratory rate of 25 beats per minute, also the indicative of atrial fibrillation. Patient blood pressure is a potential causative factor because patient has the hypertension for last 5 years and he is taking the lisinopril, by which the blood pressure is low right now, and the patient, by blood pressure we can also assess that he has atrial fibrillation. Now the plan from the two options, that is the rate control and the rhythm control. Rate control is mostly appropriate in this patient because the age of the patient is 60 years. His atrial fibrillation is long standing and may have been present for 2 months ago when the present patient experienced the same episode. Beta blocker, we advise the beta blocker such as bisoprolol in a dose of 5 mg once daily is suitable for the first line treatment for rate control. As we are giving the rate control, so first we give the beta blocker, which is bisoprolol. There are other beta blocker as well, it is carvedilol, propranolol, atenolol, but the bisoprolol is has less side effect. That's why we give the bisoprolol. If the patient experiences the asthma, the beta blocker should replace with the calcium channel blocker such as verapamil and diltiazem, because beta blocker can cause the asthmatic attack. That's why we replace the beta blocker with calcium channel blocker if the person is asthmatic. But in case the person is not asthmatic, so we give the beta blocker, which is bisoprolol in a dose of 5 mg once daily. As a patient is 61-year-old with additional risk factor of stroke, that is the hypertension and smoking, he is at moderate risk of having a stroke. Therefore, we give the aspirin, either aspirin or warfarin. So we prescribe aspirin 75 mg daily. Also, we give the digoxin. Digoxin causes the restoration of the sinus rhythm, prevent the recurrence and slowing of ventricular rate. That's why we give the digoxin 0.25 mg IV repeated to the maximum of 1.5 mg over 24 hours is given for restoration of the sinus rhythm. The lisinopril which the patient is already taking should be stopped, as he will get blood pressure control with the beta blocker such as bisoprolol. जब हम बीटा ब्लॉकर दे रहे हैं तो लिजिनोप्रिल जो कि एस इनहिबिटर है हम उसको स्टॉप कर देंगे. Now the patient counseling is very important. The patient should be advised to take the medication regularly. He should be advised to take his aspirin in the morning after the food. The tablet may be dispersed in the water or taken with whole or in the some water. Beta blocker should be taken regularly at the same time of each day. Notes: the overall risk of a stroke be assessed for each individual with the atrial fibrillation. It should be reassessed regularly as the patient risk of a stroke will change over time. The decision to use aspirin or warfarin should ultimately be based on the balance of an individual's overall risk of stroke compared with the risk of adverse effect and their personal preference. Thank you.